Hello everyone, hello doctors. So the topic for today is single complete denture. Single complete denture, the word itself says it's a complete denture in a single arch, either maxillary arch or a mandibular arch. Why do we need to go ahead with such kind of treatment planning? That is because the main aim for a prosthodontist should be preservation of what remains rather than meticulous replacement of what is missing. So what remains is our natural teeth or maybe some partial dentures which is there down. We are not supposed to extract all the teeth and go ahead with the upper and lower, that is maxillary and mandibular complete dentures. So what are we supposed to do? We are supposed to rehabilitate the patient as an in mint condition the patient has come, considering that what is remaining in the patient is also what most important. So this is why we have to know what is single complete denture. So this is what I said. Now what all things can happen with a single complete denture? That is, what are the opposing things that we can get? We can get a natural denture, that is the natural teeth which is present in the patient. We can have a partial dentures, that we can have a fixed partial dentures as well, a removable partial denture, or it may be a completely existing complete denture that the patient doesn't want to change. So he will be like, no, I want to keep my lower complete denture as usual of the last time or the previous time, and fabricate me a upper complete denture. So in that case also we have to go ahead with a single complete denture techniques. Now the single complete denture evolved with years, and there were many scientists who came ahead with different techniques. And how are we supposed to go ahead with single complete denture fabrication? So the first one was Swenson's technique, Yurkstas' technique, Bruce gave a technique, Boucher himself wrote another technique, Yurkstas gave a technique, Han-Kuang Tan gave a technique. Let's see what was Swenson's technique. Now Swenson's method was very simple method. He said that you mount the maxillary and mandibular cast. Now the mandibular cast and maxillary cast, when mounted in the present condition, wherever there will be interference, you need to mark it with a pencil and just reciprocate that interference in the patient's mouth intraorally and do those changes, and then get a new cast out of the changes made from the marked denture or the marked cast. Now when you get a new cast, now then you have to articulate back with the present maxillary or mandibular complete denture, whichever we are fabricating with. So it was very simple method. Then came Yurkstas' method. Yurkstas said that you take a U-frame shape. Now U-shaped frame, that is metal frame that he gave. Now he said that put that metal frame onto the mandibular cast. Now this was only regarded to fabrication of maxillary single complete denture, because in mandibular complete denture or a mandibular natural teeth we have curve of Spee or compensating curves respectively. So now that metal frame which was there, that was a U-shaped metal frame, so that was which was there, that was reciprocating somehow and somewhere the curve of Spee. Now whichever cusp was touching onto that and others were not touching to the cusp onto that metal frame, those were reduced, and the same was reciprocated in the patient's mouth. So that is how we got a new cast, and again mandibular or maxillary, whichever, then you have to articulate it back. Now that was Yurkstas' technique. Bruce gave another beautiful technique. He came up with acrylic resin. What he said was, take clear acrylic resin and then you put it like a putty index, you make like that same way. You make an index of the clear acrylic resin and then see where all the interferences are there. So now wherever he found the interferences, he just reduced it in the cast. The same he reciprocated with the same clear acrylic template onto the patient's mouth. Now he knows where exactly it has to be reduced and enameloplasty is supposed to be done. So he did that, and then we got a new cast from that particular technique, and then he mounted it back. So that was Bruce's method. Boucher came up with a method where he said very easily, he said mount the maxillary and mandibular cast. Both the casts are mounted first. Then what you do? Now your maxillary teeth arrangement is also done. Now after the maxillary teeth arrangement is done and mandibular, we have the natural teeth present. Now you do all the balancing movement, that is a protrusive movement, that is a left lateral, right lateral, all the movements are done with the maxillary complete denture onto that of the natural teeth, that is a mandibular natural teeth. Wherever there were interferences, we were marking it out. Now he said before doing any correction, just go ahead with fabrication of maxillary denture. The maxillary denture was fabricated And then after maxillary denture fabrication, when it was remounted, like lab remounting was done, and then he made all the interferences which was grinded in the cast, then that was put onto the intraorally and then again rechecked for the interferences, and those were removed. Elkrig-Nader's method. Elkrig-Nader's method says that you have to use wax on both the sides. Like in Bruce's technique, we used clear acrylic template. He used wax instead. He made a template of wax on both the buccal and that of the lingual side, or the buccal or the palatal side. Then he found out that wherever there was interferences, like if this was my index and some cusp is coming up on this, he reduced this particular cusp and marked it. The same wax was taken intraorally, and then he found out that okay, this part of the cusp is up. So he again reduced that particular cusp. So this was his technique, Nader's technique. Han-Kuang Tan, he came up with a very new technique, and very recently in 1997, what he said was we have the clear acrylic templates. Sorry, I'm really sorry. Now he said that we have the templates that was made of thermoplastic sheets. Now those thermoplastic sheets were attached onto the cast. Now the thermoplastic sheet is a transparent. Now that cast was attached, thermoplastic sheet was attached onto the cast. Now wherever there was interferences, you can cut those thermoplastic sheets from that particular area. So now when this is the cusp and thermoplastic sheet is all over, now you know that this particular cusp, the mesiobuccal cusp maybe, let's talk about that. Mesiobuccal cusp is higher in position. So you will cut the thermoplastic sheet from the upper part, mark it with red. So now the template that you have, that have got a hole. Now that is reciprocated intraorally, and now again the cusp will be up and the template, the thermoplastic template will go down. Now you know which part of the cusp is high in position, you trim it off intraorally, and that was a very simple method. So these were all the different techniques that we saw how single complete denture can be fabricated. Now let's see what are the common occlusal disharmonies which can be present, like here. We can see if that molar is tilted. This is how the molar is tilted. Now in the case molar is tilted, how will you make a denture over here, or fabricate a fixed partial denture over here? Because we do not have the parallel endings. These two are not parallel. So how will you do that? So we will make this wall firstly parallel. We will make a short crown out of it, where the walls will be parallel. See the second picture, the walls are parallel now. This is parallel to this. Now this wall which is parallel, and on this we will put a metal coping. Now that metal coping which will come onto this is called telescopic coping. Telescopic, like a telescope. A big, then small, then small, then small. So we have a bigger tooth, then we reduced it, and a smaller metal coping came onto this, where the walls are now parallel to each other. So path of insertion is single path of insertion. So then now we will fabricate a crown over everything. Now this is the bridge which is formed over the telescopic crown. So these kind of crowns or these kind of fixed partial dentures are called telescopic fixed partial dentures. So in these case of occlusal discrepancies, these are the treatment plan how you will change it. Now this was a template which I was talking about. Like this is a U-shaped metal template by Yurkstas. Yurkstas gave this template to put it over, and you see now this cusp is touching, this cusp is touching, and this canine, premolar and second premolars are touching. Molar is not, second molar is also not. So you will reduce the first and second premolars as well as the canine, and then now you see you have reduced this, so now it will touch all the areas, and now this template will be taken over to the intraorally and done all the changes which is required. Now this was Yurkstas technique. Now coming to what will happen, what are the achievements that will happen with a single complete denture, might happen with a single complete denture. Now for the fact, or for that matter, we all know that maxillary anterior region is the secondary stress bearing area, the rugae. So it cannot take up much stress, but though it is a stress bearing area. Now what happens, that particular area is also susceptible to have more stress if there is any natural mandibular anterior teeth present. Let me repeat it all. If the maxillary is edentulous and mandibular anterior teeth are present, what will happen? This is edentulous maxillary, we have mandibular anterior teeth present. Now it will go and hit all the time. What is happening when it is hitting? The resorption of the bone will happen. A body itself has a defense mechanism, you can say a defense mechanism by which when the body is seeing that the bone is getting resorbed too much because of these natural teeth, it produces a hypoplastic tissues, that is a flabby tissue over this. So that what happens, that flabby tissue will give a cushioning effect to the bone. So the force will not get directly transferred to the bone. So now that flabby tissue is natural because of the body defense mechanism. So what happens if we have a natural teeth in the mandibular anteriors and fully dentulous maxillary arch? Now what will happen? The bone resorption anteriorly will take place. If the bone resorption anterior take place, the flabby tissue will increase. There will be papillary hyperplasia. What will happen with the mandibular anterior teeth? Extrusion of the teeth will take place. Like in a bookshelf, if you have kept all the books in a line and on that also there are different books. Now if you remove one book from down, what will happen? The upper book will fall into that particular place. The similar thing is happening here. When there is no teeth over there to stop the action of its growth, now the extrusion of the lower teeth will take place. The mandibular bone resorption will also start off. Why will that happen? Because maxillary we have a denture. Now mandibular posterior we do not have any teeth. So those denture will again come and put some force over here. So this entire procedure which was happening, or the circumstances which are happening, is called the combination syndrome, because it was a combination of all the things, or it is also called hypoplastic anterior syndrome. Now this was discovered by Kelly in 2003. Ellsworth Kelly said that complete denture opposing a lower natural teeth or a partial lower denture will of course have these problems. Associated with that also will happen epulis fissuratum in the anterior region. It will also have a poor process adaptation, because what is happening? The maxillary is getting a tilt now. Now the maxillary anteriors are resorbing, maxillary posterior region is coming down. So what is happening? The denture is having a tilt. So now when the denture is having a tilt, the stability of the denture is hampered. Not only the stability, the occlusal plane is also now changed. It has come like this. The occlusal plane has to be straight. Now it has come like this. Now what will happen because of this? The upper denture will slide backward and the lower denture will start sliding frontways. Now because of all this thing, occlusal plane discrepancies, there will be even parodontal changes in the anterior teeth, natural teeth which were present. So in all we are hampering the entire intraoral condition if there is a combination syndrome. Now what happens with the single complete denture opposing an existing complete denture? Now it's very simple if it has to support or come ahead with an existing complete denture, because their complete denture which was fabricated before was also considered with the curve of Spee, and we have that patient is also aware of the shortcomings and upcomings of a complete denture. So now the patient, when he is receiving or she is receiving a denture on single arch, now he or she can have to manipulate it with the denture which is already present. As a dentist, what is our role? Our role remains to give a good occlusion, number one. Number two, solve the issue for which he or she might want to change the denture. That was maybe the earlier denture is not pleasing enough onto the eyes, or it is not giving a good occlusion, that is mastication was not proper. So those problems have to be considered before going ahead with fabrication of a single complete denture with a complete denture which is already existing in a particular patient. Now if it is a mandibular single complete denture, is the work a little easy or difficult? Yes, the work in a mandibular single complete denture needs too much of thinking and logical approaches. That is, we need to know the curve of Spee. We need to know the curve of Wilson, that the mandibular teeth will be lingually tilted, all the posteriors. There has to be followed a cusp line from the canine tip to that of the lower molars passing with the midline of the condyle. The curve of Spee has to be maintained. Now also how the maxillary denture is fabricated. Now you need to also follow that. We need to take care that the teeth, occlusal heights are not increasing to the retromolar pad because there is an incline. So the long axis of the force of the mastication which is coming will not take place. So all those things are there. But what happens if we have to, give a edentulous arch which is there with the natural teeth present? In that case, what we will do is that we have to apply functionally generated path technique. Now, that is where all it can be contraindicated again. Now, that can be contraindicated in the desired jaw movements and necessary needed for the reliability of this particular process. The denture space is not enough in those cases. We cannot go ahead with functionally generated path technique, and physical and mental condition of the patient is also important. Now, what is the rationale for implants in a single complete denture? I personally believe with the or even quoted in Mesh in 2003 that a complete denture, when it is supported with the implants, also acts none other like a tooth itself present naturally. Because what happens is, a tooth when it is present, the resorption of the bone is less. Similarly happens with that of the implant. When an implant is present, our resorption rate decreases. Now, when the resorption rate is decreased, the second advantage we get is we can give a palate-less denture in these cases. Because the retention, primary retention, now we are getting from the implants which is present. And this is specifically this picture, it shows a complete denture implant. Rather, it is showing a hybrid prosthesis. We can see what is hybrid prosthesis is. We have an implant. On that we have a metal framework, and on that there will be the crowns which will come. So that is hybrid prosthesis. So what are the occlusal materials for a single complete denture that we need to take into consideration? Now, the occlusal materials for a single complete denture, like porcelain teeth, it can be acrylic teeth, it can be IP and interpenetrating network teeth present. Now let's come one by one. Like firstly, porcelain teeth counts into history. Hardly we all have seen that. Now, porcelain teeth, what used to happen in those teeth was, now porcelain teeth in the ridge lap area have a metal tugs. Now, those digloi has to be putting over the metal frames. Now, the disadvantage with porcelain teeth was that it used to give a grating like sound when you are masticating. Even the another fact that the porcelain teeth were accepted in those days was, and now even now is, that the mastication, the occlusion is so superb in those cases, it can grind off anything that you give. It's a porcelain at the end of the day. It's like your fixed partial denture. So now the wear off was very less. Secondly, like you give in acrylic teeth, what happens? The vertical dimension decreases in years together. Porcelain teeth, no such problem, no such complaints of decrease in vertical dimension because it doesn't wear off. But the only thing was, it was difficult to equilibrate because it is difficult to trim those teeth if there is any interferences. So those were not used nowadays. And if at all, the porcelain teeth is opposed with the help of a natural teeth, it will even wear off the natural teeth away. So that's all the reason why porcelain teeth is counted as a history of denture teeth which is present. Now we have acrylic resin teeth. As I told you, no wear of opposing natural teeth, easy to equilibrate. The major disadvantage that it is wearing off. So what will happen? The vertical dimension will get decreased. Now coming to gold occlusals, many people in still date also uses gold occlusal. Gold as a strength has its highest modulus of elasticity. Now what happens? It is a best material to oppose the natural teeth. But what happens? The time required is more. It is more expensive to be used as a patient in a complete denture. Now what will amalgam stops? Now amalgam stop is another good thing because it has a good compressive strength. So now the amalgam stop reduces the occlusal wear, and after the acrylic teeth has been balanced, occlusal preparations are made with the acrylic teeth. Now amalgam is condensed into that preparation of the occlusal teeth, and that is how characterization of that particular denture. It looks very beautiful that it is characterized. It is not a natural. That appearance of the patient is also gone because you can see some fillings inside the denture. So it's some new feeling altogether with the patient, as well as we have an advantage that occlusion forces can be very well absorbed by the amalgam. Coming to the IP and resin teeth, which is now used widely, there is interpenetrating network teeth. On what happens that it decreases the disadvantage of acrylic teeth and that of the porcelain teeth. Now it is highly cross-linked, so the wear off is little less, number one, And the second is that the wearing off, more important than wearing off, is the balancing effect. The balancing effect of these teeth comes out to be really good, and aesthetically as well, that we are very pleasing aesthetics we obtain with the help of IPN teeth. So the denture teeth that we use today is IPN resin teeth, which has an advantage collectively of both the acrylic teeth as well as that of porcelain teeth, which has reduced or removed the disadvantages of porcelain teeth as well as the acrylic teeth. So these are the different occlusal materials that we have to use for a single complete denture depending on what we have down. Now, if for example, if you have a fixed partial denture down, porcelain teeth is not a bad option. If we have a natural teeth, of course IPN resin teeth should be the only option left. So this is how you have to plan over with a complete denture, single complete denture, opposing what exactly we have. Exactly in the opposing arch, if we have a complete denture with a porcelain teeth, of course you have to go ahead with the porcelain teeth fabrication of a denture in the upper arch. This is how you have to decide for single complete dentures.